I'd like to also introduce Pierre Jaïs, again, another person who does not really need an introduction. Thank you very much for flying all the way here from France and give us some new insights on how we might use imaging to help us in the ventricle. Thank you.
Thank you so much, Stephen. I'd like to say that I'm super grateful that finally one company has a primary focus on VT. Yeah, I think patients deserves that, and thank you for putting all your energy into this goal. So that being said, here, you know that there are limitations with conventional approaches, and there has been much improvements with navigation systems, so that you can map even in sinus rhythm and detect some of the abnormal areas in the heart that are going to host the VT circuit. And the best demonstration is, of course, when you can map during the ventricular tachycardia. But again, all of this takes time, and it's not always possible. And so there are a bunch of things that we can think about to improve VT ablation. So improved electrogram detection. Maybe we will have new mapping electrodes that will do a better job. I still think that we are somehow confused by the amount of far field in our interpretation of the current maps. And we're working with some companies, and I see Michael Bodner here. We're working with Biosense Webster on improving this. And new tools will help here, along with improved mapping software. But the point I'd like to make is on the last two bullet points. I think we will have the opportunity to have a very interesting alignment of two major improvements. The first one is the existence of digital twin and the integration of images and improved ablation. And this is where the company Field Medical and other comes in. I'd like to have this word of caution, because we all see plenty of measurements of depth for those lesions. I'd like to remind you that most is coming, of course, from preclinical work, and lesions that we see in swine are not going to be the same in patients. And typically, they're like 20% bigger in swine as compared to patients. So we have to keep that in mind. It's even worse in potatoes. Potatoes have been largely used for PFA. Be aware. This is one case that Fred Sacher, who is doing most VT cases in Bordeaux. Fred is here. Thank you for your work, Fred. It's a laminopathy. I will focus mostly on post-MI VT, but I wanted to show you also here the power of combining image integration and PFA. This is a very difficult patient with a laminopathy, and you can see the voltage abnormalities that are very limited in the most basal and septal area of the LV of this patient. And if you look at the abnormal area according to late guide enhancement, it's way bigger. So part of it was completely ignored by mapping, and there are plenty of reasons for that we can discuss afterward. I have no time here, but Fred did several deliveries with PFA on both sides of the septum, and that patient for the first time was free from arrhythmia for over 6 months now. It's a very good result because septal VTs are particularly challenging, and I'm convinced since the beginning that PFA has in fact a superior efficacy in SCAR as compared to RF. And there has been some interesting demonstration of that. I'll come back to that later. Now, image integration is, in my opinion, going to be absolutely needed for most VT ablation. It particularly works well for post-MI VT if you are using CT scan. CT scan is easy to perform. It's typically of very good quality among centers in the world. It's calibrated the same way on water, and you have a very good spatial resolution to analyze the thickness of the tissue. Interestingly enough, and much to our surprise, a myocardial infarction is very heterogeneous. You have areas where the wall thickness is super thin. This is the dark red here. And you then have areas that are, so this dark red is less than a millimeter, meaning that there's probably no fiber surviving in such a thin part of the scar. And then you have areas that are slightly thicker, etc., until you reach 5 millimeters, that is the normal. And this, if you color code it, shows you areas that are going to act as barriers. They are red. And in between, you have this yellow corridor that is going to be your slow conduction, where you have enough thickness that is meaning that you have a combination of fibrotic tissue and surviving bundles. This is your slow conduction area. It matches very well with the VT circuit when you have a chance to map it. We had plenty of demonstrations of that. It's very robust. And so you may have very complex scar, big scar, and again, you have the same color coding. We contoured in white the areas that are going to act as a barrier during VT. You may still find some very delayed potentials there, but they are not going to be active during VT. It's going to be the channels in between that we have highlighted with the green lines here. So before the ablation, you have this information. You can understand how long the case will be, and you can display your lesion set to transect all these isthmuses. Now, this is done with RF at the present time. It's suboptimal because RF struggles with fibrosis, and because you have to do multiple sites to transect one isthmus, meaning that you have a chance to have some area that is left intact and have a gap that will appear when it heals. So the workflow we have at the present time is that we would fast map the, this is on the left side, we fast map the pulmonary artery. We like working transeptal with the post-MI VTs. And once we have fast mapped that, we can register. And we register manually, but there are ways to do it automatically as shown on the right. It's one click and it registers. It aligns pretty well, by the way. So this is a very interesting case that was done in Germany. The patient had 2 ablations because he had recurrence after the first one. Now, the first one is shown in brown on that slide. This is the scar due to RF ablation as from the late gadolinium enhancement with MRI, okay? It's very easy to differentiate from the myocardial infarction. It's way brighter. And they did a good job, in fact, because there is an isthmus that is right here, okay? Because this is going to act as a barrier, this is not a barrier, and this is your isthmus. From imaging, it's pretty obvious. And they did a good job because they ablated what I think was probably the exit. It makes sense. I mean, they were right, but they ablated in an area with a large thickness. This is why it failed, and the patient had a recurrence. While the second ablation was done right in the middle of the isthmus because they knew where the most vulnerable part of the isthmus was localized. And so this illustrates the benefits of using PFA over RF. It penetrates deeper in case of scar. And I love this publication here where it is nicely shown on the histogram. You can see that you have scar versus healthy. When it's healthy, PFA and RF are going to give you pretty much the same depth. But when it's scar, PFA is way better than RF. This is really important to understand. And I do believe that this is the explanation why we were successful in that woman. I was very impressed with this ablation. She failed everything. I mean, she had 3 previous attempts. that were using endocardial ablation, epicardial ablation, even though it was a LV summit location, and alcohol injection in the first septal branch. Everything failed. She had a less than 20% ejection fraction due to the ectopics. And we did an attempt with PFA that we ended up to deliver in the aortic wall, because this was the closest area we could reach to the mid-wall origin of the ectopics. And these tissues are abnormal, surely intrinsically, but particularly after all these ablations and etc. So PF did well, and this is the first delivery gone. Never happened to that woman before. So I think the future is going to be this combination of image integration with these new devices that can create lesions that are like 15 millimeters width. This is all you need to transect post-MIVT isthmuses typically. It's like 3 of them in a given patient. So we are going to move to ablation procedures for post-MIVT that are as easy as PVI. This is really what I believe. This is where we are heading, and this is going to be a fantastic news for patients who are still receiving DC shocks at present time. So we'll make this ablation with one spot only, with no risk for absence of coalescence of the lesions, and superior outcomes as compared to what we have at the present time. And we also have the benefit of improving imaging by photon counting or our superior MR sequences. And you can run out of these images some simulation in the computer that show you the predicted VT circuit. This is the animation here, and here the circuit starts. It matches very well what we observed in this patient. So this is the future, and I thank you so much for your attention.
Thank you very much, Pierre.